Pradeep Pendyala. Wish you all a very happy Durga Navami. Tomorrow is Vijayadashmi. Have a wonderful day. Today I am going to talk to you about the importance of ECG and how much you know basically during Viva test of MD Anaesthesiology. You must be aware that William Einthoven was the father of ECG. He was awarded Nobel Prize in 1924 for discovering ECG. I'm sure a right coronary artery supplies the inferior wall of the heart. Anteroseptal wall of heart supplied by left anterior descending artery, and anterolateral supplied by the circumflex artery, and posterior wall is again supplied by right coronary artery. You should know these basics. And a current of repolarization traveling away from the positive electrode is usually seen as positive deflection, which is towards the positive electrodes as a negative deflection. The one which travels towards the positive electrode is seen as negative deflection. When the current is perpendicular to the electrode, it touches the baseline and produces a biphasic wave. I'm sure you know electrocardiograph moves at a speed of 25 millimeter per second. It's not centimeters, 25 millimeter per second. That means 2.5 centimeter per second. Time plotted on the x-axis and voltage on the y-axis. Always time is shown in the x-axis and voltage on the y-axis of the ECG. Okay, and in x-axis 1 second is divided into 5 large squares, each of which represents 0.2 seconds. Each large square is further divided into 5 small squares of 0.04 seconds each. The ECG machine is calibrated in such a way that an increase in the voltage by 1 millivolt produces increase in by 1 centimeter. The conventional 12 lead ECG consists of 6 limb leads and 6 precordial leads. Okay, what are the limb leads? Limb leads are 1, 2 and 3, AVR, AVL and AVF, and named as RA, LA, RL and LL. The limb leads are color coded to avoid misplacement. Why? I'm sure you know. Red depicts right arm, okay, yellow left arm, green left leg, and black right leg. I'm sure you know it. The precordial leads are V1 to V6 and attached to the surface of the chest. For the correct location, the angle of Louis is an option, and the exact placement you should know about it, how it is placed. V1 is placed to the right of the sternal border. V2 is situated at the left of sternal border. V4 is placed at the level of the fifth intercostal space, the mid-clavicular line. V4 should be placed before V3, and V3 is placed between V2 and V4. V5 is very importantly and is placed directly between V4 and V6. V6 is placed at the level of fifth intercostal space in the mid-axillary line. Now, talking about angle of Louis is located at the cartilages of the second rib. Okay, you can say at the beginning and end of aortic arch. That is the angle of Louis. The boundary between inferior and superior mediastinum, and location of the bifurcation of the trachea, Posteriorly, the plane of the sternal angle passes through T4 and T5 intervertebral disc. That you should know. And they may ask you about cardiac axis. Cardiac axis refers to direction of heart's depolarization. Okay, the cardiac axis is related to the area of significant muscle bulk within the conducting system. Typically, cardiac axis is between minus 30 to plus 90 degrees. A quick way to estimate the axis is by looking at leads 1 and AVF. It can be defined as normal axis when the QRS complex is positive in both these leads 1 and AVF. A left axis deviation between 0 to minus 90 degrees is defined by the presence of positive QRS in lead 1 and negative in lead AVF. And right axis deviation is what? It is between plus 90 to 180 degrees by the presence of QRS negative in the lead 1. QRS is negative in lead 1 and positive in lead AVF. Okay, in both QRS complexes are negative in leads 1 and AVF. It is termed as extreme right axis deviation. That means between minus 90 to 180 degrees. There are many other methods also, and you should know there are several disorders in which cardiac axis deviates. The best examples are inferior MI, inferior wall MI, left ventricular hypertrophy, bundle branch block like left bundle branch block. The left axis deviation occurs while right axis deviation in conditions including right ventricular hypertrophy and hyperkalemia, pulmonary hypertension, and Wolff-Parkinson-White syndrome. You should know all this. Okay, and right atrial hypertrophy shows an increase in the amplitude in the first half of the P wave by 2.5 millimeter. It is often termed as P pulmonale because frequently associated with chronic obstructive lung disease. Left atrial hypertrophy shows an increase in amplitude and the duration of P wave. And you have to know this. There's no second thoughts about it. And the right ventricular hypertrophy characteristically shows right axis deviation and the presence of more significant R wave compared to S wave. Okay, right ventricular hypertrophy normally shows right axis deviation and right wave, significant right wave compared to S wave in lead 1, whereas in lead 6, a more significant S wave compared to R wave. Left ventricular hypertrophy similarly has voltage of R wave in V5 and V6 plus S wave in V1 or V2 exceeding 35 millimeter. When you add all of them, it will be exceeding 35 millimeter. Okay, to identify is a left ventricular hypertrophy. Infrequently, there is also the presence of secondary repolarization. The presence of secondary abnormality, secondary repolarization, including T-wave inversion and downsloping of ST's depression. Now, what is this PR interval? It represents the time from the beginning of the atrial depolarization to the start of ventricular depolarization. The average interval is 3 to 4 small squares. That means 120 to 3 to 5 small squares. That means 120 to 200 milliseconds. Okay, now you should know variations in the PR interval can lead to various disorders. Like long PR interval may indicate first degree AV block. Short interval may be present in conditions with accelerated AV conduction such as Wolff-Parkinson-White syndrome. Now what is this second degree heart block? It's is of two types, Morbid's type 1, also known as Wenckebach's block, and Morbid's type 2. In type 1, the block across the AV node, bundle of his, is variable and increases with each ensuing impulse. On ECG, if it shows as progressive prolongation of PR interval and then suddenly a P wave is not significant, is followed by the QRS complex, this sequence repeats itself in a regular manner. Most patients with Morbid's type 1 second degree AV block are asymptomatic, whereas Morbid's type 1 AV block may occur in the setting of acute myocardial infarction or myocarditis. Bundle branch block results from conditions either left or right bundle branches. Width and configuration of QRS complexes should be noted. The right bundle branch block is represented on ECG by the presence of widened QRS complex greater than 0.12 seconds, along with RSR pattern. RSR pattern should be significant in V1 and V2. Okay, in right bundle branch block. And there may be ST wave depression and T wave inversion and reciprocal changes in leads V5 and V6. Conduction system disorders can cause the right bundle branch block, but it may present as a standard variant in specific individuals. Whereas the left bundle branch block is represented on the ECG by a widened QRS complex greater than 0.12 seconds, broad and notched R wave, and prolonged upstroke in V5 and V6 and AVL, along with ST segment depression and T wave inversion. Okay, then QRS complex. What is QRS complex? It represents ventricular depolarization as current passes down the AV node. The standard QRS complex has a duration of less than 3 small squares. That means within less than 120 milliseconds, usually 60 to 100 milliseconds. A prolonged QRS may indicate hyperkalemia or bundle branch block, and a premature ventricular contraction or a ventricular rhythm can be associated with a wide QRS. Now, what is this R wave? It is the tallest wave of the QRS complex, and it represents the electrical stimulus as it passes down the ventricles during depolarization. The R wave progressively increases in amplitude moving right to left in precordial leads, and is called R wave progression. Lead V1 has the smallest R wave. Lead V6 has the largest. A reduced R wave progression has several causes, including prior anteroseptal MI, left ventricular hypertrophy, or inaccurate lead placement. Posterior wall MI manifested as horizontal ST depression in leads V1 to V3 and is associated with tall R waves and upright T waves. Likewise, inferior wall ST MI, that means ST elevation MI, produces a reciprocal ST depression in leads 1 and AVL. And there is often a reciprocal ST depression in leads 3 and AVF in lateral wall. Okay, during lateral wall MI. Then ST depression are also associated with several non-ischemic causes, including digoxin, you can say digoxin, normally digoxin, toxicity, and hyperkalemia and hypothermia, and also tachycardia. Okay, ST depression can be seen, digoxin toxicity, hypokalemia, and hypothermia. Now, talking about QT interval, it represents all start of depolarization to the end of repolarization in ventricles. The normal QT interval duration is somewhat controversial, and normal QT interval is less than 400 to 440 milliseconds, okay, ms, or 0.4 to 0.44 seconds. So, you should know about these things. Have you heard of U wave? It is a small wave that follows the T wave. It represents the delayed repolarization of the papillary muscles or Purkinje fibers. It is commonly associated with hypokalemia. Similarly, J wave. J wave are known as Osborn wave. It's an abnormal ECG finding in hypothermia, J wave. It appears as an extra deflection on ECG at the junction of QRS complex and ST segment. Now, what is epsilon wave? With this, I'll conclude my lecture. Epsilon wave is a small positive deflection, usually found buried at the end of QRS complex, and is characteristic finding in arrhythmogenic right ventricular dysplasia. Thanks for patient listening. Take care. Until next time. Bye bye.